So assessment of intermediate coronary artery lesions is of utmost importance in single vessel disease of stable coronary artery disease with intermediate lesion, in multiple coronary artery disease where we want to know what are the lesions that are causing the ischemia, and also in acute coronary syndrome where we want to know the physiological consequence of the residual lesions. Angiography alone is insufficient in most of the cases, and so we have to use tools. We can use tools like physiology for with FFR being gold standard, and we can also use imaging, which give us anatomical diagnosis. And we are here to answer the question: can we use this anatomical data in some way to give some idea about physiology in a way that is equivalent to FFR? So physiology, apart from FFR being gold standard, apart from telling us about the severity of the lesion, also tells us about the size of the perfusion territory, the viability of the myocardium, the absence of a prohibitively high microvascular disease, and therefore it has resulted in better clinical outcomes when it is seen. Of course, we have been debating this point over a period of time in this session. But the limitations of FFR are that it does not provide us any information about the anatomy of the morphology of the lesion. It's technically challenging, unreliable in ACS and serial lesions. Of course, the serial lesion issues has been addressed to a little bit by the use of hyperemia-free indices, and it provides us little help in procedural planning or post-PCI optimizations. So we have intravascular imaging, which tends to overcome all these limitations of FFR. We have excellent morphological diagnosis with intravascular imaging that allows us to better plan our lesions, calcified, fibrotic, thrombus, and so on and so forth. We can look for malappositions, underexpansions, stent edge dissections, and therefore optimize our post-PCI results. The question really is, can we predict physiology to the tune of almost being equivalent to FFR by intravascular imaging? Now, numerous trials have tried to address this whole issue of trying to find an equivalent MLA which corresponds to an FFR positivity. The data with intravascular ultrasound is a little larger than the OCT, but essentially what we have found that those clinical trials of intravascular imaging that have tried to find some correlation between a mean cutoff MLA with FFR positivity. And when we try to do that, we have to remember there are many caveats into it. Whenever we're trying to find that mean cutoff, we have to look for what is the kind of vessel that we are dealing with. Is it the left main or the non-left main disease? The cutoffs will depend on that. They will depend upon the ethnicity. Asians cutoffs are different from Western cutoffs. And of course, they will also depend upon what is the FFR value we are trying to correlate with those MLA values, whether it's 0.80 that we are changing or a 0.75. But overall, given the summation of all the data for the left main disease, that mean MLA cutoff comes out to be somewhere between 4.5 and 6 millimeters square for left main disease. For Asians, it's predominantly somewhere hovering around 4.5, and for the Western counterparts, they are hovering somewhere around 6 millimeters square. That relates to FFR positivity. For non-left main diseases, it is hovering somewhere between 2 to 4 millimeters square in various studies. So meta-analysis have also found the same kind of things, but this was the very good landmark paper, and sometimes I feel that the first paper that answers a fundamental question tends out to be the most elegant of the lot, and this was way back in 1999 when Dr. Atsushi tried to show that MLA of less than 3 predicted an FFR of less than 0.75 to the sensitivity of tune of 83% and specificity of 92%, but when you combine MLA with area stenosis, the predictability became nearly 100% sensitivity and specificity to more than 90%. This was an elegant paper way back in 1999, and the world had to wait for another 13 to 14 years before the second large paper was published on these issues. That is the first study published in 2013. And here also it said nearly the same thing, that MLA cutoff of less than 3.07 millimeters square best predicted the FFR of 0.80. They further went on to show that this MLA cutoff may be different for different reference vessel diameters. For example, for vessels that were less than 3 millimeters, the MLA cutoffs that were showing FFR positivity was 2.4 millimeters square. The vessels between 3 and 3.5, it was 2.7, and for those vessels that were greater than 3.5, it was 3.6 millimeters square. Meta-analysis essentially have shown similar kind of results. The MLA cutoffs for non-left main diseases being 2.6 and for left main diseases being around 5.35. And then there are various studies that have shown different values for Asians, between Asians and Western counterparts. For example, but more or less the figures are hovering somewhere around for left main disease. For IVUS, it's somewhere around 4.5 to 6, and for non-left main diseases, anywhere between a 2.5 to 4.0. Now, OCT trials and studies have also followed the same pattern, and but one thing we have to see that the mean cutoff values of MLA for OCTs are relatively lower than those that are for that we have seen with IVUS for FFR positivity, while it was ranging in the left main diseases between 2 and 4.0 with IVUS. Here it's somewhere around 1.9 to 2.5, and this is comparable to the other known fact about OCT, that it tends to underestimate the lumen when compared to IVUS. So recent trial outcomes, I'm not supposed to speak about clinical data, and I think a lot has been said, but 3 recent trials that have come out just for reference sake between OCT FFR is FROZA trial, and we have Flavor released this year between IVUS and FFR, and then we have Insight trial just released last year, which compared endoguided to IVUS to OCT. But I'm not supposed to speak about them, and Dr. Mintz have spoken extensively about the clinical trials data comparing the 2 strategies. But here I am to raise a little bit of controversy, and I would like to have your point of view on that also. I think there are a lot of fallacies about MLA-based FFR prediction hypothesis, because it is difficult to assign a specific number to an individual patient based upon the mean value in clinical studies. The mean value in clinical studies, if a 4.5 with the left main disease, it essentially means that half of those patients with FFR values of less than 0.8 would be more than that figure. So it's very difficult to assign a specific MLA finding and try to base your clinical decision upon that based upon the mean values of any clinical trial. And we also, very importantly, we have to remember that the MLA cutoff and FFR positivities are much better related in left main disease than in non-left main disease, owing to the limited variability of left main length, diameter, and we are reasonably sure that the amount of myocardium being supplied by left main is essentially almost always very, very high. We also have to remember that going further on this point is that in left main, the data of that 4.5 and 6 has come from those clinical studies that have studied isolated left main ostial and shaft diseases. But this comes in very handy when we are also dealing with complicated diseases of left main bifurcation and ostial LAD, because here it's very difficult in the presence of complex left main bifurcation diseases. It is very difficult to assess, impossible to assess the physiological significance of an ostial, of a shaft disease from FFR, and here these MLA values come in handy, and they tell us whether to include or not to exclude the left main shaft and ostium from our decision making based upon the clinical studies. But when you come to the non-left main diseases, using just MLA or MLD to predict physiological consequence or an FFR positivity is probably an oversimplification of a complex question. FFR positivity of a lesion in an individual patient may depend not only upon that MLA cutoff, but it will also depend upon the reference vessel size, thereby percentage area stenosis, location of the lesion, whether it's located proximal, mid, or distal in the artery, the length and morphology of the lesion, the area and viability of the myocardium being supplied, and of course the nature of microvasculature. So all these factors in combination will affect the physiological consequence in the FFR value, not just the MLA cutoff only. So here we were trying to associate an MLA with an FFR, but we can go further, and now we have imaging derived FFR values. For OCT, you calculate the area of every OCT slice, and for OCT, you calculate area for every slice lumen area, and for IVUS, you calculate every 1 millimeter slice lumen area. You apply some basic fluid dynamic equations and mathematical calculation model, and you can come up with something that is called as the OCT derived FFR, which is much more comparable to the measured FFR than the OCT derived MLA. Similarly, IVUS-derived FFR is much more comparable with the standard measured FFR than the IVUS-derived MLA. Now, apart from the intravascular imaging, we have other modalities of imaging that can predict physiology, and one of them is the CT coronary angiogram. This was the first paper, the landmark paper published in 2011 by Dr. Koo et al., the Discover Flow, in which, which set the ball for the CT-FFR findings. And CT-FFR essentially follows the same principle. If the CT-FFR values are greater than 0.8, then it is relatively no further testing need to be done. Anything less than 0.75, one should go for angiography, and anything between 0.75 and 0.8 is the gray area. Another advantage of a CT angiogram based FFR is that while in the FFR, of course, one, that it's non-invasive, but it also gives the collective, it also gave the individual for every single vessel, while for invasive FSR, you can only interrogate one vessel at a time. So we have to remember one thing that I want to highlight here is that when we are recording, when we are seeing the reports of a CT-FFR value, we have to see for the value that is 1 to 2 centimeters distal to the lesion that we are interrogating by that CT. And there are two reasons for the same. One reason is that just beyond the stenotic segment, there is something called as a pressure release, and the FFR, the CT-FFR values may transiently rise. So we have to give it a little gap, go further down to around 1 centimeters. And also because sometimes even without any focal significant lesion, the CT-FFR values will keep on decreasing towards the end of the vessel and may become, positive towards the end of a vessel without any. So we can't go too distal, you can't go too close to the vessel. You have to measure somewhere in the range of 1 to 2 centimeters distal to the lower border of the stenotic lesion being under consideration. So here you have a significant lesion somewhere in the proximal LAD, and you can see CT-FFR values going transiently down. This is the example that I was talking about. There's no significant lesion, a focal lesion, but the FFR values keep on, CT-FFR values keep on going down, and they become positive towards the lower end of the artery. So these arteries need not be, these are not of very significant lesions, so we have to measure at a very specific areas. And here again, you see two tandem lesions in proximal and mid LAD. You see the FFR values become 0.74 distal to the proximal lesion, and there is a second lesion where the values become 0.06. The point I want you to highlight here is this artery in the diagonal, a little below the proximal lesion, where the FFR values are actually gone up. This is what is the pressure release phenomena. So you should measure the FFR, CT-FFR values 1 centimeters distal to the lower border of the segment in question. We of course have QFR that is coming up now. It's basically a combination of a three-dimensional QCA in which you have we have to reconstruct the 3D model of the angiogram in two angiographic projections with angulation 25 degrees apart with minimal overlap and foreshortening, and then you combine it with the with the flow rates in terms of and then you get the QFR values, and the QFR values have been proved to be in Flavor 1 study in 2016 and 2018 Favor 2 study. They have been shown to be associated correlatable to FFR values, and Favor 3 in China study, we have found that there is lesser MACE rate when QFR was used. These are two clinical scenarios here when we have used angiogram, OCT, FFR, and QFR in the same patient. You see here there are two lesions, one tight one and one a little distal, a doubtful lesion. When you see for the CFR values, you see two pressure bumps here. So both these lesions were significant, and they have been proved on OCT findings also, the mean MLA of 1.87 and 1.24 here. But this is an interesting case where an acute coronary syndrome in LAD, totally occluded LAD around 7 days back, and this was a residual disease in the circumflex. Visibly, the circumflex looks significant lesion. The MLA on OCT is also 1.95, also looks significant, but we found that the FFR values were negative, and the QFR values were also negative. That goes on to denote, to show that it's just not the MLA, it's the area under supply, it's the nature of the myocardium. Everything combines to give us a whole degree of information and not just a simple MLA cutoff values. I would like to conclude by saying that the gold standard to assess physiological consequence of an intermediate coronary lesion is still FFR. There are many shortcomings of FFR that are addressed by intravascular imaging. Left main disease MLA cutoffs have got better correlation in predicting FFR positivity than non-left main disease. Using just MLA cutoffs as surrogates for FFR positivity is oversimplification of a complex problem, and newer techniques hold much promise to predict physiology by imaging, like OCT-derived FFR, IVUS-derived FFR, QFR, and FFR-CT. Thank you for your attention.